All right, welcome everybody as you file in. I always say this, I've been saying this lately. I feel like I always imagine a classroom, the doors are open, people are coming in, sit down, get comfortable, meet the teachers, meet the presenters, meet the host. We had a really good response to this topic and this presentation tonight, so we're expecting a good crowd. Luckily, you don't have to sit in the crowd, you just get to sit in your office or your home and or your car and listen. But again, welcome everybody here on a Wednesday night with MedMasters. We have our at least monthly webinar where we do presentations. Sometimes we have guests, sometimes we don't. Tonight we do. Dr. Suzanne Ferree is here, and she's been with us before talking about peptides. And tonight we're having her speak on Procaine or neural therapy. The end of every month, we have our community mastermind, which is just an open forum to come in and share and learn, ask questions. And last month, several like the top most common questions revolved around Procaine and neural therapy. So I thought this was a great time to have Dr. Ferree back on, especially because she's doing a formal training in her office in Georgia in like a month and a half tops, November 1st and 2nd. So I think we were also just discussing there's so much, it feels like neural therapy was one of the first things I ever learned in this world of medicine 15 years ago. So to me, it's like a staple. It's a fundamental thing. It is something like in that practice where I first started, it was our first line of medicine. We always wanted to go direct to, reset nervous system patterns and cellular communication, because yes, things could be musculoskeletally off. They could be, there could be barriers, there could be deficiencies, there could be all these things that you would need to address in any situation. But the nervous system being the ultimate communicator, we always went there first. So we'd inject scars first. We would always ask. All of our intake paperwork was always geared around what scars do you have, what's your past trauma, all these things. So it feels so fundamental to me. But then we've moved away from it. You don't hear much about it, and then it comes back, and here we are again, and it's awesome because I still think it's as great as it ever was. And Procaine itself kind of comes and goes. Sometimes it's harder to get than other times. So anyway, we're excited to have Dr. Ferree to talk about this, and she can give a little bit more background about how long she's been doing it. I was in your office end of May and got to see in real time how you do this, and the few different specialized injections that you do, and can attest to, I even got some injections that day. So it was nice to have some people I trusted to give me some localized Procaine injections. So again, welcome to MedMasters. I'm Kim Look. If this is your first time here, I am I don't know what I am, what do we call it? The CIO or something, innovation, the host. Well, I'm just their host today. Always want to be bringing relevant content to you providers, things that are going to keep you cutting edge, help your patients, and do it in the safest and least expensive ways. And so here we are with Procaine and Dr. Suzanne Ferree. So thanks for being here, Suzanne.
Thank you so much, Kim. I love coming on and talking with you, getting a chance to catch up. I'm going to jump right in so that we can get to the Q&A at the end, because I know a lot of people had a lot of questions. Most of this is geared towards the stellate and the IV therapies. So the neural therapy that you were referring to initially is, there's a whole category of treatment that involves just using Procaine in very localized ways, like treating scars, etc. So that is a whole other category for another talk for another day, because this is a big subject. But let me go ahead and get started. I'll share my screen.
Yeah, and while you're doing that, just everybody who's listening, and keep in mind, if you have a computer or even a phone accessible, please use the chat to ask your questions. We will go through this presentation that might answer some of your questions initially, but be thinking of and typing in your questions. We'll wait till we get finished with the presentation, but we do want to address all those things as good as we can, also stay on topic and stay on time. So please use that chat feature, and we will use it as well to share links and other things as they come up.
So this is Exploring Life Extension and Nervous System Regulation, a Century Uncovered. I know that MedMasters really loves to give relevant, useful information. So as you're going through doing any research on your own, please know that this human animal dose conversion chart can be super helpful. So make sure that you're looking at the human animal dose conversion, whatever the animal dose is. You can, if you go in the last two columns to the right, so you find your animal to the left, like if the research was done on a mouse, you find your number on the last two columns on the right, and either divide the animal dose by, in the case of a mouse, 7.4, in the case of or you can multiply it by 0.135. So that way you would get the human equivalent dose based on body surface area. So this can be really helpful when you're looking at, why isn't this peptide, small molecule, whatever, why isn't it working as well as I would expect it to? It might be because we're not using a high enough dose. So definitely worth having this in your back pocket all the time. So let's talk about now Procaine. This has been around for a very long time, over a century and a quarter, where it was originally developed and the cocaine was the original anesthetic that was used for surgical anesthesia. It went through several iterations, and because of the addictive properties, they converted it into Procaine, which is what we know now as Procaine. The brand name is Novocaine. However, Novocaine has lots of preservatives in it and is no longer available. So we do use the good kind, which is Procaine itself. The scientific basis of doing neural therapy in general, as Kim mentioned earlier, is intelligently using our autonomic nervous system. So remember, you have the somatic and the autonomic nervous system. Somatic is like, I'm going to grab this fork and put something in my mouth. The autonomic nervous system is fight or flight, or rest and digest. And that's really what we're working on. Lots of things can be stored in our nervous system, and there are lots of ways that we get sort of stuck, and chronic pain syndromes can begin. Also, things like chronic pancreatitis, etc., can occur because of the autonomic nervous system dysfunction. So I'll go on and we'll keep discussing how this is really critical in the pattern of healing. As I mentioned, fight or flight, rest and digest. And this is a beautiful drawing to help you sort of think about how each of the nervous systems innervates the various parts of the body. So you can see sympathetic on the left is innervating eyes, salivary glands, respiratory passages, etc. And parasympathetic innervates the same areas. What we want is for there to be a beautiful balance between these two. Let me flip to the next slide. A beautiful balance between these two, where let's say you're walking down a dark alley and you hear a noise behind you and you turn around because you're scared and you go, oh my gosh, there's something happening. And you see that it's your spouse and you go, oh yay, hello, hi honey, I'm so glad to see you. And your nervous system comes right back down and you go have dinner together. And so this, ideally, the nervous system would float back and forth between parasympathetic and sympathetic, depending on the needs of the system at the time. Many of us, however, get stuck in this sympathetic overdrive, which is dampening the vagus nerve. Vagus is brain to intestines, if you just sort of generally think about it doing that, and everything in between. And so if we can get this back in that beautiful Goldilocks middle, that's where we're really working. We would really like to see. So things that would happen, the homeostatic things are blood pressure, heart rate, digestion, respiration, and circulation, immune response, and inflammation, all are affected by this sympathetic dominant state that many of us find ourselves in, including us as providers. And so what happens when the sympathetic nervous system is upregulated, we begin to get this disruption of the microcirculation, the neurotransmitter profile. The intestines are the biggest source of many of our neurotransmitters, GABA, serotonin, et cetera. And so the neurotransmitter profile changes. This vasoconstriction begins. There's an altered metabolic state of the tissues themselves, the extracellular matrix. And so you're getting decreased oxygen and nutrient delivery, a drop in pH, and release of inflammatory mediators. So when I was studying infertility in medical school and doing research on how do we decide as an infertility clinic which follicles are going to be the one to be the most successful, we were looking at the extracellular matrix, the oxygen and nutrient and pH of the area around the cells themselves. So by doing that testing, we could determine which follicles were going to be most likely to develop into a healthy baby. And that was very exciting. It's not very practical. The testing, at least at the time that was available, wasn't very practical, but that was a while back. And so anyway, the autonomic nervous system is very much in the fascia. So the fascia is not just a covering over our bodies. It's not just a little surface cover. This is the place where the autonomic nervous system really goes and is involved. So if you have a trauma, like a surgery or other traumas, infectious causes to your fascia, this is really where we're going to get into trouble and where the neurotherapy is the big target. So the overactive sympathetic nervous system has been associated with ischemic heart disease, heart failure, hypertension, kidney disease, diabetes, obesity, sleep apnea, preeclampsia, ulcerative colitis, a host of things. And certainly don't ignore the mood disorders. It is cardiovascular disease. Here's an article. These are from 2019, 2023 on sympathetic nervous system and osteoarthritis. There's a newer one that just came out 3 months ago involving the sympathetic nervous system dominance and cardiovascular disease. I remember the cardiologist when I was in medical school saying, absolutely not, cardiovascular disease has nothing to do with stress. Okay, he's wrong. Sympathetic nerve activation, and here's specifically heart disease in vascular smooth muscle cell hypertrophy. That's where we really see the problems occur, and then the development of atherosclerosis as a result. So these are things we can do to reverse that. This is a study on two studies rather on renal function and sympathetic nervous system activation. In metabolic disease, it's sort of chicken or egg because this activation can lead to insulin resistance, but also elevated insulin level can lead to increased, it sort of feeds upon itself and can cause more problems. So this is one of the reasons why people have difficulty when they're overtraining or undernutrition because of that sympathetic dominance. We know that the sympathetic nervous system works via nitric oxide, and this is part of the production of inflammatory cytokines that go into the problem. This is one of the ways we know that Procaine works and why I mention it. There's tons of articles here demonstrating the association. Of course, your vagus nerve and is very intimately involved with the gut and the microbiome, and that it is activated. So vagus nerve activation, meaning calming, more parasympathetic by the gut microbiome, and the cholinergic anti-inflammatory pathway. You might be familiar with that from if you used what's it called, Alka-Seltzer Gold during the recent virus that we had. That Alka-Seltzer Gold works via the cholinergic anti-inflammatory pathway to attenuate inflammation. That's how it works. And so the vagus nerve being activated by our good bugs in our microbiome can improve that intestinal, decrease intestinal permeability and attenuate inflammation. And here's a study talking about attenuating gut barrier injury after injury with vagal nerve stimulation. So there's lots of ways we can do vagal nerve stimulation. Breath work is a great way. Exercise is a great way, especially intermittent high intensity interval training. We know that the stellate ganglion, and I tell patients, it lives right back here in the back of this great big muscle called the sternocleidomastoid. And if we can, this is sort of the motherboard of the entire upper body autonomic nervous system. And so this is a great way that we can treat PTSD. This is one of many, many studies that are available now. This one's from 2022, using the stellate ganglion block to treat PTSD as an option for treating PTSD. We know that it will improve nerve growth factor, norepinephrine, that it improves that autonomic controlled fear memory. So that fear of a situation, you've been in the situation before, something that looks similar to the situation, you have a fear response. And so that vagal nerve stimulation in a good way, vagus nerve stimulation in a parasympathetic way can control that fear memory. And that can be sustained for up to 3 to 6 months, even though they're just using a local anesthetic, even a temporary local anesthetic. This one, again, works by the alpha-7 nicotinic acetylcholine receptor. And this is the same thing we see with Alka-Seltzer Gold and other anticholinergic, anti-inflammatory pathways with the brain and neurons. And that's the biochemistry behind the efficacy of Procaine and of vagal nerve stimulation. And so we also know, curiously, that stimulating the vagal nerve by whatever mechanism can release pro-resolving mediators, which I thought was really a fascinating study. Again, this is 2019, fairly recently. And so this is one of the reasons why it's so helpful for all these other disease states. It promotes that M1 to M2 phenotype change. This is in your microglia and your macrophages, and decreases the movement of nuclear factor kappa B from the cellular milieu, the outside the nucleus into the nucleus. That happens in the face of infection or inflammation or trauma. That nuclear factor kappa B will go like a tattletale into the nucleus and say, oh my gosh, mom, the sky is falling, everything's terrible, send out all the troops. And vagal nerve stimulation can inhibit or decrease that. In this particular study, they were looking at reperfusion injury in heart disease. This is a study in interstitial cystitis being very involved with sympathetic nervous system dominance, so might be a way we can use it. So why do we use Procaine there's lots of things about Procaine. Procaine's the shortest acting, it's only 20 minutes. And so we think about, why are we using Procaine specifically? And one of the biggest reasons why we use it specifically is because of how it's metabolized by the body. The metabolite PABA is anti-cancer, anti-Alzheimer's, antibacterial, specifically Pseudomonas and Staph aureus, antiviral, specifically HIV and influenza. It has high antioxidant capacity, anti-tubercular, anti-convulsant. It is helpful as sunscreen. They use it now in a topical for sunscreen. It inhibits cholinesterase, so you can think about the ways that we might be benefiting from that with our Alzheimer's patients. It is an antihistamine. It seals up capillaries so that you're not getting that vasoconstriction and that sort of leaky vessel problem. And then it also stabilizes membranes because it binds to them on the cell itself. And this is a great article if you wanted to take a look at PABA as a metabolite. So this is another metabolite, diethylaminoethanol. And it's very involved in the biosynthesis of membrane phospholipids. So I can see comparing Procaine IV with phosphatidylcholine and using this as a part of your lipid rescue program. And so it does, the DEAE also increases hepatic incorporation of amino acids into proteins. So you're taking those proteins that you're, amino acids that you're digesting and adding them into proteins themselves, so protein synthesis. It also inhibits fatty acid, this hydrolase, which will increase the endocannabinoids. So that can be really helpful for pain, for sleep, for anxiety, etc. And this is unique. Those two metabolites are unique to Procaine. None of the other metabolites have those. None of the other amide based, like lidocaine, tetracaine, bupivacaine, etc. None of them have these metabolites. So in this study, senescent rats, they gave them 10 milligrams per kilogram, which is human equivalent 1.62 milligrams per kilogram IM daily for 3 days. They had an improvement in their oxygen consumption. So they're looking at mitochondrial function. That's what we're talking about in this study. And so it's facilitating oxygen transport toward the mitochondrial matrix specifically by modifying that membrane structure. So can you imagine pairing this with things like phosphatidylcholine, pairing it with things like methylene blue, so you're increasing that oxygen delivery. You could even pair it with ozone itself, and you're getting this really great mitochondrial boost for these patients that are suffering with mitochondrial disease. Did you guys see recently that test that came out called MeSense? I don't know if anyone's tried it yet, but it's pretty interesting testing. It's home testing. You can do it at home. Patients can do it at home for a mitochondrial function. So it might be valuable to do the test, do this kind of treatment, follow up. That might be a study that somebody wants to pursue. Maybe me. I just saw that come out the other day. So pretty interesting. Long-term antidepressant, anxiolytic effects, very relaxing. If you've never taken Procaine IV, I recommend you try it on yourself first. It is super relaxing. So you can, of course, throw it off, as you can with many therapies. If you are particularly anxious, you can take 10 milligrams of Valium and still throw it off and still be anxious. But if you're welcoming to the therapy, you can get a really lovely anxiolytic effect. And because of how it works as I think I have a slide on this in a minute, as a serotonin and dopamine reuptake inhibitor, you'll get that antidepressive effect as well. So just do be aware. I think I have a slide on this, but do be aware of patients who are taking SSRIs, SNRIs, dopamine agonists, that they need to probably space it apart from the dosing of that, just for possible, there's no study that shows it, but for the theoretic risk of serotonin syndrome, especially with the SSRIs. It does increase blood flow to that anti-inflammatory receptors, and then it can improve hemodynamic effects in the heart. This is tiny, sorry. The membrane itself, this resting cell membrane, this is one of the ways that it works, is by changing the voltage on the cell membrane. So normally it should be a negative charge at negative 70 millivolts. And this is with the sodium and potassium on either side of the cell membrane. And then with this chronic or severe trauma, you're going to see a decreased cell membrane potential to around 40 millivolts, negative 40 millivolts. So now you get impaired intracellular metabolism and ion exchange. So now the cell can't get the nutrients it needs. It can't get rid of the toxins it has. And so it's unable to maintain that resting potential. So you may not have a cell that dies, but they're not functioning optimally. They're generating senescent cells. There's a cell danger response occurring, an inflammatory thing. And so this can become a chronic process. And so you can get this permanent excitability of the sympathetic nervous system, the perivascular system around the sympathetic nervous system. And so Procaine can allow that, if your cell is like a battery, it can allow that partially discharged to restore and reboot your autonomic nervous system, improving capillary perfusion, improving microcirculation, etc. It is vasodilating. It modulates that mitochondria. It's also involved in DNA methylation. I don't have time to go into it, but it can be cancer inhibitory. So if you want to do the research around that, it can be part of your protocols for that. And again, antioxidants, so a high redox potential, excellent for your athletes, for your elderly who are suffering with high oxidative stress state. So this is just a summary of the things that I just talked about. It can improve fibroblast motility and cell proliferation too. So when we specifically compare it to Procaine and to lidocaine, they're both short acting. The Procaine's a little bit shorter, 20 minutes versus 60. The membrane stabilization and vasodilation is unique to that, to Procaine. It does not occur with lidocaine. And I have a slide in a minute that shows you that what it looks like when you inject it into the subcutaneous. The Procaine alone acts on the central nervous system. This is what I was talking about, inhibiting reuptake of serotonin, dopamine, and norepinephrine, as well as that NMDA glutamate receptor. Less effect with lidocaine. The toxicity of Procaine is half that of lidocaine, and because of that, you could use it potentially if you have to in pregnant patients. I don't recommend it. Versus these other longer ones, of course, they're much longer. They're amino amide linked, so they don't have the metabolites that Procaine has. This one lasts 6 to 8 hours, is much more potent than lidocaine, lasts a long time as a slower onset. So my concern with using something like bupivacaine is I want to see the patient have an effect right away, especially if I'm doing a stellate. I want to see their Horner response. I want to know what they're going to do. I have them hang around for 10 or 15 minutes. I'll go into that in a minute, but I have them hang around after the stellate to make sure they're not going to have any negative reaction. And if you have a delay of onset of that because you're using something like bupivacaine, there's a possibility they would get in their car before they would have a reaction. And so I just don't want to risk that. It's another reason why I love Procaine, because you're going to get the effect pretty much right away. This is that picture I talked about, and you can see lidocaine's on the left with it blanching out white, and then Procaine's on the right giving you that lovely red hyperperfusion or extra perfusion, and you'll see it. Sometimes their whole area where you've done injections will turn red. I like to take their phone camera if I'm doing, this is neural therapy in this picture, and take a picture of it for them so they can show it to all their friends, and I just ask them to tag me in it. And so this is a quaddle that we use in neural therapy. This gets taken up by the nerve cells right there. If I use more than about 1 ml, I can feel it in my brain right away. It's very, it gets taken right up by the nerves in the skin and can be very, very effective. So why do we use sodium bicarbonate? That's another question we got. And this will increase the intracellular procaine concentration. That's why we use it. It will accelerate the initial effect. So patients are going to feel it quickly and they'll have a strong response to it. So ideally, and I think I said say this in a slide in a minute, but you will prep them ahead of time for what to expect. I'll tell you what to expect in a second. But you'll get impressive results with severe cases of pain and inflammation when you add that bicarb. If you're doing neural therapy, that bicarb just adds a little bit of gentleness so that they only feel the stick of the little tiny needle. They don't feel the burning of the Procaine itself. So that can be also calm them down a little bit, make them more receptive to taking up the medication. When given intra-articularly, bicarb plus Procaine is superior to dexamethasone in recovery. And I have a patient just now, I think this is related to I don't have a specific study showing this, but I'm guessing this is related to the antimicrobial effect. There have been a couple of studies that have come out in the last 1 to 2 years showing that osteoarthritis has there's some lipopolysaccharide in the joint itself. And so using bicarb Procaine, and then we also will use a little bit of ozone in those joints, at least as our first treatment, so that they will be able to get rid of that infectious component to their disease state. Okay, so what kind of effects can you expect from Procaine? People will get a little bit dizzy. They might feel warm, slightly sweaty. Many will get a metallic taste in their mouth. Often they'll feel shaking, but not have any visible tremor. Most people, however, report a sense of calm, well-being, euphoria. And I have a few patients who've said, wow, I feel safe for the first time in my life. This is, of course, mostly my PTSD patients, but it's extremely calming. We have them lay down for the administration of whatever we're giving them. And so those are the big ones. Yeah, Procaine toxicity. So in a 70-kilogram adult, you can do up to 500 milligrams of Procaine, which is 25 milliliters of a 2% solution. I think most of the studies go up to 300, but we do push it to 500 if patients tolerate it. This is particularly relevant if you're combining IV with a stellate or with a neural therapy treatment. Just keep in mind what your max dose is and where toxicity will begin. The allergy rate for Procaine is well below that of many others, particularly the other local anesthetics, and then also antibiotics, anti-inflammatories, and antihypertensives. So very low toxicity and allergy. Versus an allopathic nerve block. So what we're doing in our clinic is not an allopathic nerve block. There is a lack of studies. There are no head-to-head studies, but the American stellate ganglion block usually uses long-acting anesthetics like bupivacaine or ropivacaine, often coupled with steroids and generally performed under fluoroscopy. So that is the traditional American stellate ganglion block. And the goal of that the goal of the traditional stellate treatment, like what we're talking about, the centuries old, almost, a little over a century old treatment, is a reset, not a block. All I'm trying to do is allow the cell to go, take a deep breath, go back to doing what it's doing. I don't want to knock it out. I want it to this is Goldilocks, right? We're trying to get back into that middle ground. So here's a case study. This is a 63-year-old white female with complex PTSD. She had both a childhood trauma, a prolonged childhood trauma, and then she sustained a neck fracture while she was working as an inpatient social worker with children. A 13-year-old attacked her, grabbed her by the neck, slammed her head against the wall, fractured her cervical spine. She had severe debilitating cervical pain, was on oxycodone, diazepam. She was agoraphobic, was in her home for 13 years on disability, unable to work, light, sound, and motion sensitive. She couldn't get in a car. She couldn't drive a car. She couldn't go to the grocery store. She had, gratefully, many friends on whom she could depend, but this was really tragic. She did undergo several epidurals, all the medications I talked about, the American stellate ganglion block, without relief. So I finally convinced her, will you please just let me do one? Just let me do it one here in the office. You can bring your best friend. I don't care. Bring 10 best friends that can stand around you. We'll pray. We'll do whatever. Just please let me do it. So she finally let me do it. We did 10 of them, and she was able to drive to her visits unaccompanied. She's now working again. She's working 3 days a week. She's thinking about starting to date. I mean, this is huge for this agoraphobic woman. You can't imagine. This is like 3 cats, or 5, sorry if you have lots of cats, but this is like a typical agoraphobic person. And she is stepping out and into the world. And it's so exciting to see this happen. So this is going to be the case with your patients. It's super exciting. So there are multiple ganglion infiltrations we can do. If you're familiar with the Eastern beliefs about chakras, they're located where the chakras are. So the stellate is here in the neck. The celiac is just in the abdomen, just above the umbilicus. There are 2 inferior hypogastrics. These are beautiful. They look like the veins on a leaf. And like there's 2 of them that lay sort of in the bottom of the pelvis like this. The sphenopalatine, which is accessible through here, you go under the orbit into, it's sort of, if you do your hand like this, it's sort of right there between, if these 2 fingers met. And then the otic is, you can access it through the side of the jaw, and then the sacral, of course, you can imagine where that is. So we're just going to talk about the stellate today. This is, there's usually 3 or 4 thoracic ganglia that are involved there, and then the inferior cervical is all together right there. The branches of this go to the lungs, heart, aorta, esophagus, thyroid, brachial plexus, middle superior cervical ganglia, and the carotid plexus. So knowing that, what do all those things innervate? Think of all the things you could do with a stellate. If patients are having Hashimoto, this might be a case for you to treat with a stellate. So if patients are having reflux or heartburn or intractable vomiting or what's it called, hiccups, this might be something for you to consider treating. We use this for atrial fibrillation. We use it for lots of other chronic diseases. So anything really from the top of the head to the upper abdomen, that's what we're going to use the stellate for. Carotid plexus, talking about heart rate rhythm. Here it is again, vagus, glossopharyngeal, superior cervical. This is where it's located. As I said, I always tell patients, it's right here in the back of your neck, behind this big muscle, the sternocleidomastoid. What also lives there? The beautiful carotid. So that's the only reason we have to be concerned. The big reason we have to be concerned. This is a cross section just to give you the same information. As I mentioned, this is the stellate, this is the carotid. So in our class, we teach that you how to move it out of the way so you can get right to where you need to be with landmarks, and no imaging required. Traumatic, these are indications for a stellate. As I mentioned, many of them before. Think again of all the things that are innervated by that group. Be aware that sometimes patients will experience a strong emotional release. And I tell them that up front. You may experience a strong emotional release. I give them a couple of tissues because they often will burst into tears. With neural therapy or the ganglion treatments or the IV, I give them a little handful of tissues because it's very normal. That's exactly what we expect, is them to have an emotional release. They may not have it on the first one. They might just have it on the second one. They might not have it for the first 5 and they have it on the 6th one. It depends. Everybody's a little bit different. So just let them know that might happen so they're not surprised or worried about it. If you can get them to journal in the moment, that's ideal, because then you can really, I tell them, this is your purging. You're just purging all the stuff that's coming up out of your tissues. And so then you can get integration, reframing, improved mood. This is particularly when we're talking about our PTSD clients or our anxiety, insomnia clients. We get increased pain acceptance and empowerment of the patient. And then sometimes if they have this mood persist, it's typically no longer than 2 days. I haven't seen anybody have it that long. Most of them, it's just a couple of hours at the outside. The majority of patients are 20 minutes. This was an interesting study. So this is complications associated with the stellate ganglion nerve block. Again, this was done 2019, so recent research. 51% of the adverse events were using imaging and 48% were using landmarks alone. So note down this study, because this one is one you're going to want to hold on to and maybe you have to use for the medical board, God forbid. And so this is just saying the difference between using imaging and not using imaging, using landmarks alone, is very similar in the risk of adverse effects. And so this is why one of the reasons why we don't use imaging in our practice. I also, in the stellate, imagine having to find your landmarks, hold your image, then get your, I don't have enough hands for all that. So I can definitely feel where I need to go. I can feel where it's happening. I can do the stellate. I can feel with the needle, the resistance against the needle if I'm in the wrong place. It's, now so this is your study to prove that what you're doing is safe. So let's get into IV Procaine. I can go back and answer any questions you might have, but I want to make sure we get through the slides. IV Procaine is in anti-aging, heart, kidney disease, pancreatitis, mood disorders, including PTSD, infectious or inflammatory disorders. We'll often use IV Procaine to start. So because patients are sometimes nervous about having a needle put in their neck, so they will tolerate a needle in their arm. So we'll do a low dose Procaine IV and say, oh, look at how it's not that big of a deal. An adjunct to cancer therapy, as I mentioned, in asthma and allergies. Forgive me. Do not use Novocaine, even if you can find it. Please don't use it. It's got preservatives. It's not safe for use, particularly if you're using it IV. You want compounded, sterile, preservative-free Procaine. You want a 2%, which is 2 grams or 2,000 milligrams per 100 milliliters. These are 3 of the compounding pharmacies that we use, and frankly, we just switch around for the cheapest guys until, we'll use one for a couple of months and we'll switch around to the other one for a couple of months. I don't usually have any trouble finding Procaine. Most of the time it has to be refrigerated and kept away from light. So we use those big, the 5 cc syringe boxes that the syringes come in, and we just pull all the syringes out, fill them with Procaine, put the needles on them, and then put them all back in the box. And then the providers can go and grab from the box when you need it for not for IV particular, but for neural therapy. So you want to do an initial visit consent, and I think Kim has consents and SOPs for you that you want to do an H&P, and really you're just looking for what are your indications for giving this to the patient. And then are there any contraindications like allergy? I have one patient who is allergic to Procaine, so I certainly wouldn't administer this in her. You plan for about an hour infusion time. We're going to check their urinalysis ahead of time for a pH. Anything greater than 7, I'm not going to give them the full dose of bicarb, which I'll tell you in a minute. Anything less than 7, I'll probably go ahead and give it to them. If I'm seeing them several times in a row, I'm going to trend that. So let's say they start out at 5.5 or 6. God forbid one of our patients shouldn't be at 5.5 or 6, but let's say they're at 5.5. I'm going to just trend that. And if I see it's heading up and it's 6.5, then I'm going to go ahead and give them back down on their bicarb dose as they get closer to 7. Most of the time, these patients are going to need bicarb every time. But if they have known heart disease, I just want to have a pre-procedure EKG. We do those in our office as an extra, side thing. But I think that's valuable to have if you just get them to bring from their primary care, get them to bring an EKG from their primary care. So you just have a pre-procedure EKG and you know what their baseline was. And then prepare the patient in this initial visit for what their potential side effects might be. So the protocol is a 1-to-4 ratio of 2% Procaine to 8.4% bicarb. The reason I keep hammering on the fact that it's 2% Procaine is because when we do neural therapy, we usually dilute it to 1% or 0.5%. So just be aware that when you're doing IV, you are doing a 2% Procaine. 8.4% bicarb we get from McKesson or Bessie or someone normal. That's the standard concentration. If you've mixed this and it's been 2 hours, do not use. So if we're doing neural therapy, we keep a bottle of bicarb in the drawer in the office, in the exam room, and we just pull up like a little 0.2 bicarb into the 5 ml syringe. But we can go into that later. You're going to start with 2.5 to 5 milliliters of that 2% Procaine. You're going to do it in 500 milliliters to 1 liter of saline. You're going to drip it very slowly. I just want to see like drip, drip. The patient's going to let you know if they have any problems. If you've given them NAD in the past, or anybody NAD in the past, you know how they sometimes will get that chest tightness at the beginning of giving them NAD. Sometimes if you give it to, they might get the same effect with Procaine. In the same way, you're going to stop or slow down the rate, wait a few minutes till the symptoms clear, and then restart at a slower rate. And then as they go, you can usually go ahead and bump that up as they're going. So no problem. It can be used up to 3 times a week. Definitely monitor their urinalysis at every visit. We usually do once a week. That's pretty standard. Unless they're coming in with sort of something acute, then we'll do it more often. But the chronic disease states, chronic pain problems, we'll do once a week. They usually require 6 to 12 infusions. We'll increase doses to that max. So start out with 2.5 to 5. The next visit you do 5 or 10. The next visit you do 15. Next visit 25. Let's say it's 6 months later and they're like, hey, I want to do another series of Procaine. We start them at whatever their max dose was. You don't have to go back through the lower doses. All you're doing is trying to make sure that they tolerate it. We sell it in 3 to 6 infusion packages. We can, as I mentioned, combine it with phosphatidylcholine or methylene blue, or I love to combine it with metenkephalin, and we'll just do Procaine with bicarb, and the second bag is that metenkephalin in a little, we call them sippy cups, that little 200 ml or 100 ml bag. And they get a really nice pain relief with that combination. You can chase a Myers with minerals and aminos to help with optimal nutrient uptake. Remember, the base, the sodium bicarb can improve the nutrient delivery, intracellular nutrient delivery. And so if you're giving your Myers or minerals or aminos, that can certainly be helpful. And then you want to monitor their SED rate and CRP, just because you're going to see it improve with these patients with these problems. You can continue monthly to quarterly for anti-aging, autoimmune, or cardiovascular maintenance. So we typically will do a weekly series at the beginning of 6 to 12 treatments, and then we'll do a monitoring for whatever their disease state is, renal function or heart, heart disease or whatever. And then we will back that off to quarterly or monthly or quarterly based on how they respond. Patients who are taking nitroglycerin, calcium channel blockers, beta blockers, just know that they're more likely to experience palpitations, flushing, or syncope. And you just go a little bit slower, start at a lower dose at the beginning. Of course, all of your limey moldies are going to experience more side effects. And so start with a lower dose, go more slowly. They may need 2 weeks in between treatments because of their reaction. And then other side effects, they may become hyperactive. And what most of my patients describe as tons of energy, that's what I hear them say, because a lot of them are coming in fatigued. So we'll have them tons of energy. And sometimes that can result in insomnia. So let them know that's possible. And then they may get a temporary headache that's from the medication itself that almost always goes away with the second or third treatment. Some of them will also get vertigo. So I make them all lay down, hang out. We turn a little cafe light on. We have some good music going on, and let them just chill in their room, try to keep them away from their phone during that time, and let them just hang out. So if this is interesting to you and you want some more information, and particularly a hands-on practice building, patient healing, practical application, community building, networking event that is for you, please don't miss our neurotherapy conference. This is the QR code. It is November 1st and 2nd here in Roswell, Georgia at our office.
You are picking up speed like Lexi and I talking a mile, talking like super fast to get through it all. As I thought, like you answered so many questions along the way. It was so great. And while I was mentioning like this is kind of foundational, you said things I haven't heard before. So that's always what getting the practical knowledge and also the current studies will definitely bring to the table. So I'm sure everybody loved the presentation the same. We do have a list of questions here. I've written down questions that we can go through as well. And we're going to leave up this slide for a little bit because some of these questions Like what are landmarks, different things like that. I really feel, tell me if I'm wrong, but I really feel like you need to be in office to see those things to, I mean, we definitely wouldn't want to give enough information here where you go test it out without proper train and cause some problems. So, there's nothing like hands-on and actually being able to hold those. I assume you're letting other people do the injections too at your course.
Oh yeah, you're going to be doing them and receiving them at the course. Yep, you'll do stellate, celiac, inferior hypergastric. Mhm.
Is that what you're mostly focusing on the course also is those types of injections and IV? Are you doing scars? Are you doing all of it there?
All of it. It's a 2-day course.
Okay, so all the more reason to go. Um, and be able to again see those landmarks, get the experience, both what it feels like and then also doing it on other people. It's a very, very, very cool therapy. I have been training in office locally to me. We've done 3 or 4 days of on-site over the course of a few weeks at least, and had different candidates each time. Every single person immediately within a couple of hours and within a couple of days and a couple of weeks have experienced a wide variety of responses. I feel like that's like, is this normal? Is this normal? Is this normal? Is this normal? It's like, Suzanne went through those like most common responses and the things that we hear and report, but it's so vast. And I feel like the things that you said even make it seem like such a panacea. Like, I feel like it would be easier to say what are the list of contraindications than the list of indications, because who doesn't have stress? Who isn't in fight or flight for just like driving down the freeway or having kids or like you said, being providers, practitioners, entrepreneurs? So I think that's also very wise to get your experience first in this proper setting. Network with that group in the moment, and also, I'm guessing because it's in your office, you're going to have it a pretty small but intimate group where you can really get some good interaction and good experience too. But then as you bring it into your practice, it's like the responses you get are just mind blowing and also very unique. So I've got some questions based on a lot of that stuff. And we can go through, I think you answered a lot of these as well. So it might take us a minute or two to get through some of these. And yes, it's being recorded. Yes, we will send out the recording in a couple of days. Yes, you still need to go to her class November 1st and 2nd in Georgia. It's really beautiful there. It's really easy to get to. Office is fantastic. Melissa, your nurse practitioner, is another big reason to go. She's amazing.
Brilliant.
And has such a great energy and teaching capacity and treats so many people. I think you probably get the gist. When they take a box of syringes, replace it with Procaine, probably like you probably do this every couple of days because you use so much Procaine in your office.
It's almost every day.
Yeah. I mean, would you say it's the most common therapy you do?
It's almost always one of our first line therapies.
So it's like every patient that comes in, you're like, how does Procaine relate? Which Procaine injection should we do? Kind of like which peptides would be for this patient? Yeah, it's a staple once you learn it. It's kind of fascinating that it's not more common. And I've been talking about it a lot in the anti-aging side, which is some of that you didn't talk about Anna Aslan a whole lot. I don't know if you mentioned her at all, but the anti-aging perspective is centuries old. I mean,
Yes.
it's been around a long time, and here we are in 2024 really focused on anti-aging. But there's, again, I just feel like there's so many applications. And the other thing, last thing I'll say is, what other options are there to treat stress, to treat trauma? I mean,
I
it's
mean, there's
they're not
lots,
great options.
breath work I think is really helpful. Ayahuasca probably is a good, not in the United States, but elsewhere is a great option. Um, Doing things like psilocybin has some really great, all of those are terrific as far as their efficacy is under the guidance of a healer who
Right.
knows how to help with guiding you through that because it can be complicated, especially ayahuasca. Those are some emerging therapies that we may see be beneficial in the future. Certainly, breath work is something that you can do on your own at home. You can learn how to teach it. You could do it for your clients on your own. This is certainly something that's doable to yourself or to other people. If you just go on YouTube and look up breath work, there's a million breath work teachers there. And
And
so
now you're
that,
talking about having to change behavior. That's like, I mean, when you look at the practicality and even the cost, Procaine is super inexpensive. Even like
so
the cost
inexpensive.
of like resetting the nervous system so quickly, getting a real quick response. That's another reason I like this, like you mentioned, like within 20 minutes, you're gonna know how this person is affected, and they are going to know, right? There's nothing more powerful than feeling it. Even
Yeah.
though so much about our nervous system we don't necessarily consciously calculate. One thing that comes to mind you didn't mention either is ketamine. So
Yeah.
how
Oh,
do you
yeah, for
really compare
sure.
this to ketamine?
So it's of course different, and ketamine is so specific to that IDO pathway in the brain. So yes, it's awesome, but it's very specific. Where this is much more broad in how it works, not only on the brain but also on the heart, on the liver, on the kidneys, on the you're fixing all these places because all that trauma is stored in the tissues. So as you're able to get it released, you should be able to do better. And again, the ketamine is very specific to where it works in the brain.
And that is safe, right? Like it's, I mean, it's such an ordeal.
Ketamine.
Yeah.
So we do it intranasally just because it's effective, and patients over time the IV ketamine doesn't they'll be, initially they're going once a month, and now they start going every 3 weeks, and then they start going every couple of days, and you're like, why don't you just use intranasal, because it works. And so they get really good results if we do it that way. And they might require both. That's certainly possible and
Oh,
reasonable.
okay. Interesting. It's not a true replacement for it then, but it is more broad scope.
Ketamine or,
Yeah.
or Procaine.
Well, Procaine for ketamine.
So I found it to be super helpful. Just realize if you're treating complex PTSD, the research shows you're looking at 18 weekly treatments.
Of ketamine.
No, I'm sorry, of Procaine,
Of Procaine. Okay.
of stellates. You're talking
Okay.
about 18 weekly treatments of Procaine stellates to get the effect for PTSD. And that's been about my experience. Patients will start to back off on their dosing at about back off on how frequent their frequency at about week 12. But they still get those last 6 treatments. They're just spacing them further and further apart.
Okay. Got it.
So,
Got
mhm.
it. All right, where do you source it? You answered that question. I'm always a big fan of Texas Star. I even saw that some of them might have been on here. Innovation, Pure Pharmacy. I think they all make good. I think you have to have accounts with all these different places and just make sure you've always got some options. Yes, we're recording. Yes, on slides. What percent strength of Procaine? 2% for IVs, 1% for others.
Yes, unless the patient is particularly sensitive, and you might need to dilute it again to 0.5%. So if when you're injecting, this is really for neural therapy, if you're injecting those quaddles and the patient's like, ow, 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 and they just don't tolerate it, you can decrease that down to 0.5. Of course, I think adding bicarb is the solution because they don't have that pain response when you give them when you put bicarb in there. So we haven't had to dilute to 0.5 because we've had such a great response with adding bicarb.
Check on this, but I thought Texas Stars had some bicarb in it.
I hope not.
Yeah, am I wrong on that? Maybe I am. Or at least you had the option.
It'll break down at 2 hours.
Okay, so I must be entirely wrong then. We can check with them, but it must be totally wrong there. So it's got to be added separately and in the moment. That's why you keep the bottle in your, okay. Um, and you did show a slide of how much sodium bicarb to Procaine. I also know, like you said, at the very beginning, this chart on weight per dose, et cetera, is going to be super helpful. And you might even need to increase it. That's in the slides, but is there a place to just go find that?
Oh, let me see. I don't remember where the slide was. It is a 1-to-4 ratio. The bicarb to Procaine is a 1-to-4 ratio. So if you're doing 5 ml of 2% Procaine, you're going to do 25 ml of 8.4% bicarb. If you're doing 25 ml of Procaine, you're going to do 100 ml of bicarb.
Okay. How do you or can you combine this with IV ozone therapy? You touched on it a little bit. I'd love if you spent a second or two expanding.
Yeah, absolutely. Because of how it helps with oxygen delivery to the mitochondria, this could not be a better pair of doing IV ozone with the Procaine. This can be super helpful for like wounds that aren't healing well. There's a lot of trauma that's carried in a chronic wound, so certainly that would be a great place for you to do Procaine plus ozone IV. Absolutely. Anybody that's having decrease in blood supply to an area for whatever reason, and so that might be
I was just
because
gonna
of
say that even if it
cardiovascular.
yeah, increases circulation before you gave the IV Procaine, it might even just expand on that circulatory capability. You said
Absolutely.
something too about, I love that you said this, some of the infections we're now seeing in joints and some of the studies showing that. But when you do Procaine, some people can feel it in really specific areas. I did one the other day, she felt it in her ear. I mean, just
Yes.
here, slightly muffled. They can, I see a lot like limbs, of course, genital areas. I think those become pretty standard. But have you noticed that a lot of times people will feel it where their infection may be?
Yes.
And then that would also be a reason to add some Procaine as well. Plus, it's not Procaine, ozone. Procaine's going to numb it just a little bit before you add your ozone in too.
Absolutely. So we use it. Don't forget about your teeth being your biggest. We didn't even talk about interference fields. That's a whole other conversation for another day. But the teeth are a big interference field for a lot of disease states. So if you're not seeing your patients respond to Procaine, how you're hearing us talk about they respond, it's probably because they have a big interference field. And one of the most common interference field is a dental, a post-dental procedure. So root canals, old root canals, or tonsillar beds. So we'll often in the office be shooting people's tonsillar beds, shooting their teeth where their root canal was. We use Procaine, then we'll come behind it with some ozone and get that, really try to kick that infection out. And often you'll see what we call a lightning response. These are neural therapy terms, but you'll see that lightning response where, wow, they've had this toe pain for 6 months or a year or 15 years, and you shoot their root canal, and oh my gosh, all of a sudden the toe gets better, completely unrelated, nothing to do with anything else. It's very strange to see that happen, and I've had a couple of those. It's very interesting, and you're so grateful that you pursued
Yeah.
that. The
Yeah, you
fanny
did
seal,
mention it though, like these meridians and how they connect. And the European training that I got, that was a huge focus. I'm sure you're going to do it in November too, but you can inject there's connections, right? So you can inject the tonsillar bed and see pelvic pain improve, right? And that's phenomenal. And that's also why it's like, is this normal? Well, yeah, all these things are connected and they're all electric too. There is an electrical charge, a transmission that's happening cell to cell, spine to nervous to tissue to organ. Like all these things make a ton of sense when you look at it that way. And again, I feel like there's just not very much out there that's healthy in terms of conventional medicine that really can approach this in this type of way. And I wanted to ask you this question. How do you define this reset capability? You shared so many studies that are so great and how it can, some of those pathways, some of the results of that. But there's a lot of research showing that cells even retain trauma, they retain memories, and that I always say the extension cord might kind of be plugged into the wrong area, right? Like you're trying to turn the light switch on and off, but the cord is just going into the wrong spot. And so if you just kind of shut it down and plug it into the right areas, now the light turns on in the right spot or it turns on in the right, depth. And so it's like shutting down your computer and restarting it. And those memories, do they fade? Do they completely go away? I mean, it doesn't change the trauma itself, but for some reason, your ability to handle it does dramatically change.
yes, and this can be really helpful in those patients who are. So we have another complex PTSD patient who came in many, many, many times she has a dog that comes in with her, an emotional support dog that's been trained. Whenever her anxiety kicks up, the dog starts to act out. It whines, it cries, it jumps
Right.
on her because it's trying to distract her from her anxiety. So as soon as it senses her, I mean, I love dogs, isn't that beautiful? But as
Yes.
soon as it senses her anxiety, the dog starts whining and like needing her attention. And oh my gosh. So that's been her therapy for her PTSD for many, 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 many years. Well, she responds, she did not respond well to the stellates. She would throw them off every time we'd give them to her, but she responded great to the IVs. And so she's now, I think, about 12 or 15 in, and she's driving herself. I mean, these are dramatic life stories where people are getting such improvement, like they're back to their normal functioning. So this is super exciting.
It's another thing you just triggered me is the way you said, unless you've done this therapy and had this therapy and even seen 20 or 30, patients with this, you won't necessarily understand this. But when you say welcoming to the therapy or throwing off the therapy, um, I could go down that road quite a bit, but it's something to really be mindful of is to allow your patient to relax, to accept, if they come in really high strung, if they're in a state of manic, if they're already really ramped up in terms of nervous system, they could totally throw this off and you might even see them get worse, right? Like it almost heightens these symptoms and then they think the Procaine did it, but you really have to be open and welcoming to what this is going to do and how it's going to feel. I say this all the time. If you're somebody that doesn't like to let go, to lose a little control, then this may be almost act like a trigger when their system is a little out of control, right? It's resetting. And they have to be very aware. I think that takes the longest with this therapy is the explanation, setting the expectations for the patients. What can they feel? What might they feel? And even walking them through it as they feel it. It really is the most time and energy consuming. I think in an IV room, it's not you start it and you walk away. Like you oftentimes need to almost be their therapist as you go through that. So I highlighted that. I loved how you said that, like welcoming to the therapy.
We have a couple things we do to help mitigate that with using like the brain tap or having them put on headphones and listen to binaural beats or other forms of I love listening to I think the Spotify station is called Relaxing Indian Flute Music. I love that stuff. I can listen to it all day long. It's so relaxing. And so I'll put that on for our clients who are in the IV room when they're going. Again, once they have the first treatment, they know what to expect. It's not
Mhm.
scary. They're fine. And in fact, most of the time, you've already established a relationship with them. You're not going to do this straight out of the gate when you first meet them on the first visit. This is something you're going to work them up to. You're going to say, I think one of the things we should think about doing is a stellate or a celiac or an inferior hypergastric. I'm going to put great big needles in your neck and your belly and in your pelvis. No, you don't do that on the first visit. You just explain to them that we have this therapy that helps reset your nervous system. A lot of disease states are due to, a lot of the things I said to you earlier in the talk. And then the next visit, you say, have you thought any more about that? I think that would really be the next step for you. And it's one of the least expensive, most effective treatments that we do. So I'd love to see you add that to your regimen that you're already doing.
Yeah, for those of you that might be thinking about adding this into your IV space, I love group therapy rooms in that for so many reasons, right? The energy can be so great. You've got a lot of camaraderie, you've got a lot of community there, a lot of encouragement. This is an IV though, where some of that could be a little bit overstimulating or it's what you said, it might throw off the treatment when they're not able to just close their eyes, sit and relax and accept it and take it in and let their nervous system calm. That can be also a reason why they may not get the result, or you might even see them like really visibly uncomfortable and even vocally uncomfortable because there's too much stimulation in that room. So I know Suzanne does this in your office for some of these injections, but I would we've even done it for pushes and things where we will put somebody in one patient, one room, privacy, lay them down, turn the lights off, turn on your flute music, and really let them engage in that and accept it and just relax. Like, I feel like there's not enough space for that type of environment anywhere these days. So it's very cool, but it also is not, a very quick thing all the time to just get it and go. In fact, I like to do it, by myself on a Friday night, like, and just be able to totally, like, I think you mentioned it too, just like keep them off their phones, like try to encourage them to relax and not keep the stimulation going because it won't have the same effect. So, another question here, do you prefer ozone and then Procaine or Procaine and then ozone? Do you have a preference?
I usually do Procaine and then ozone.
Interesting. Going to Ilad's meeting the next week, next course offered. Oh, that next week, next course offered. Do you have a second one planned? I think is what this is.
Probably we're gonna do it. Probably we're gonna do it in February or March. I don't have a date yet for that, but we'll probably do a second one in February, March.
Yeah, Saudi, I did see you register anyway. So Saudi is a pharmacist at Texas Star. It's a huge
Oh,
fan.
yay.
Yes, she's here. I haven't read this yet, but I had the same question, I think. One of the slides said to combine with, I actually reached out to New BioAge because they spoke on methylene blue. We had some experience with it here at our local office in combining some of these things. Thought he was asking the same thing. So what do you actually combine in the same like IV bag versus maybe succinct IVs that you always have to make that like separation? So she says combine with phosphatidylcholine or methylene blue doesn't mean in the same IV bag. If so, do we need to amend the max dose from 25 mils of Procaine 2% to a lesser dose?
Not in the same, at least in the state of Georgia. I don't know what the rules are everywhere else, but I believe the rules are very similar everywhere else, that you cannot put more than 2 things in a bag at the same time. So we usually will do, I get a bunch of those sippy cups, the little ones. So they might have, a little, I don't know why we call them sippy cups. I don't know.
It's cute. It's cute.
250 ml, the little ones.
Yeah.
And we'll put like, this one has Procaine, this one has methylene blue, this one has phosphatidylcholine, this one has, whatever. Or we'll do it with our EBOOs. We'll do, okay, they're going to get their EDTA, and then they're going to get their EBOO, and then they're going to get their Myers with minerals, follow whatever. They're going to get all those things. And so we'll on their IV pole will be each of those 3 or 4 little teeny, their sippy cups on their IV pole.
Okay, so there's a legal reason. I reached out to New BioAge and Saudi, if like from a from a chemical standpoint, is there any sort of interaction or reaction if they were to touch? Because we did this back to back, and my instinct was to flush the line to get all of like the methylene blue out or the Procaine out before I put the next one in. And I was like, I just don't know. I've never done this to know if there's any sort of reaction there that might be unwanted, unnecessary.
That's how we do it. I just want everything to be clean. And I just want to know if you're going to have a reaction, which one you reacted to.
Mm.
So that's exactly how we do it, Kim. Flush the line, start the new one.
Okay, so do you amend the max dose from 25 mils of Procaine 2% to a lesser dose?
I do not.
Okay, that's if we're mixing, I think is what she's saying. I don't know what you mean there, Sandra. Zen Vagus nerve stimulator by Nuvana. Oh,
I don't know that product, but there are lots of vagal nerve stimulators, and they're all effective in a very, I like Apollo Neuro. It's a good, another good one. There's lots of vagal nerve. There's a little one that you can buy. I can't remember what it's called. I get it on Amazon, and it just sits in your hand, and it's just a little like, it's a little like a TENS unit almost that you hold in your hand for helping with sleep. But it's a vagal nerve stimulator in the sort of a backward way. Yeah, but all of those can be very helpful. All you're trying to do is get vagal nerve stimulation. Like I said, breathing, intermittent, intervals, high intensity interval training, and breath work. And like you're talking about, lots of things can be vagal nerve stimulating. Eating.
Yeah, right. Okay, good question. If they get good results, Asadi is saying in terms of mood, but I would say anything. Do you still continue to titrate the dose up, or do you stay where they got result?
So it depends on what you're treating. If I'm treating PTSD, I'm going to go ahead and push their dose, and push it to whatever they tolerate. And let's say we get to 10 and they don't tolerate it, and I'll say, okay, next time we'll go back and we'll do 5. Great, no problem. But almost always they can tolerate 10 the second time. So we'll either stay at that same dose again or back down to the previously tolerated dose. Almost always they can tolerate it the second time.
You know what I do is I increase the dose, but I may slow down the drip.
Yeah, great.
Like it, so it kind of feels the same, but overall, they're over more time, they're getting a higher dose. That's,
Yes.
I don't know. And then of
Just
course,
be,
you go.
oh, just be aware that they can get a little bit of that hypoglycemic effect. So have them bring a snack. That's part of your conversation when you're talking to them in their initial visit.
Definitely, but some of those symptoms can definitely mimic the either or, they can be or mimic. Yeah, I know Texas Star the best. I don't know in terms of what state. California is always hard. In fact, Saudi will tell you like we don't even want to go there. But Innovation, Pure, I'm guessing you don't know if they're in California or
I
Alaska, right?
don't.
You guys will just have to look them up. We actually have a link to both. If you go to lookforthecause.com, there's a link to Innovation, I don't know, but Texas Star and Pure. So there's direct contact information there to just make it easier for you. Yeah, Saudi. Okay, so Texas Star does not add sodium bicarb. Good to clarify there. I'm so sorry I even mentioned that. That was that was gotta add that in separate. Do you add the Procaine right into the IV ozone bag, or do you do the IV separate Procaine first? I
So
would
you can
say
actually do both. That's one that I would do both. I would put the Procaine right into your ozone bag. So add the ozone to the bag, add the Procaine to the bag, mix it up, and then administer to the patient.
And I love that standard of care could also be that you chase it with some vitamins and minerals. Because again, just how the cells work, the cell cycle, the lack of nutrients, the hydration, like all of things will make the Procaine more effective and also help the patient through that process. I wanted to ask this question. Do you see the release? You talked about emotional release in the beginning. Number one, I would say I've seen that the emotional release isn't always crying.
Mhm.
Sometimes that emotion is different. It can be maybe some of the anxiety, maybe it could be some anger, maybe it could be it happened to me once where I just became like extremely competitive, but I went from an IV, a Procaine injection, it wasn't IV joints, to a tennis match, and I was just like so intense. And so it doesn't always have to be that crying emotional release. The second thing is though, do you feel like almost like the emotional detox is a very similar symptom to what they're already having, like maybe an increase in anxiety or some of those trauma responses?
Yes. So it also will cause a response that you wouldn't necessarily see. So in our PTSD patients, for example, where they're like, I never cry,
Yeah.
often we'll see that come out. So I actually like to use the word a purging. This is a purging. This is your body like letting go of the things that were so, so awful, the stored emotion in your tissues. And so you want to not shame them around having
Right.
emotions. And so saying this is your body, oh yes, good, this is your body purging, let it go, excellent, woohoo, so it's a celebration in our office when people have a emotional release. The one patient that really strikes me that I hold on to the story about, she had a fairly traumatic childbirth, and the baby, they were having trouble getting the baby out. It was all turned around. I don't remember all the details, but the OBGYN had pressed on her xiphoid process and fractured it off of her sternum.
Wow.
I mean, pressed so hard that she fractured her xiphoid process. So she was in so much pain. This whole situation was terrible. Baby was taken rapidly away from her, taken to the ICU, la la la. So there's all this emotional trauma that's now stored in this area. And she wasn't aware of that being a problem. She knew it had been always painful, but when we were doing her exam, we're pressing around, and we talk about the exam in the conference, but we're pressing around and pressed on her xiphoid process. She hadn't even told us this story. press on that, and she was like, oh, like really bad pain. We treated that spot one time. The pain was completely gone, but she had a huge emotional response to that treatment.
I have a very, very, very similar story that I always tell that's very compelling. It's amazing. And she was like 40 years post that experience.
Yes, this woman is in
She,
her late 60s.
yes, 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 and had had many children since and was thought it was all fine. And even when she was like crying like crazy, she's like, I don't even know why I'm crying. It's like your body does. Your body has stored this up. And then every single one of her female symptoms went away after that.
Yeah.
Yeah, it's incredible. All right, Buddy Green, welcome. Thanks for being here. It's a good question. Do you find taking PABA as an oral supplement have some of the benefits that Procaine therapy does?
It should. You're gonna get some of that, yes. Mhm. But why not just infiltrate it around your stellate and get all the benefits?
Totally agree. Like, and I don't know, gut processing, right? There's always going to be some delay there depending on the gut health and whatever, but it is, we're always looking for instant gratification in this world this day. And this is the one thing that might be able to give it in a really healthy way. So I do
And
love
it's
that.
so
Um,
inexpensive relative to your other therapies that you do on a regular basis.
Totally, totally. Somebody did ask about cost. I don't know what you charge, but I've seen everything from $100 on a simple injection, $150 on a lower dose IV, up to $300. I think obviously it kind of is relative to the other costs in your office, your overhead and so forth. But is that about the range that you're charging?
Yep. So we're a concierge model. So our concierge patients, we charge them. I think we charge them like $50 if it's up to 25 ml of 1%, and then we charge them like $100 if it's over 25 ml of 1%. And then if it's a non-patient, because we do see some non-patient neural therapy for neural therapy, and those patients we charge 250.
Yeah. Um, I love your concierge model. We were always both Lex and I were blown away by the affordability for your patients. It's really sweet of you. Um, all right. Is the this is a good question too. Is the therapy effective with ADD, ADHD, hyperactivity in children? I've seen lots of varying responses to this.
Yep. So I don't see children, so I can't really comment, but we do use it in the ADD adults, the adult attention deficit. And yes, it can be super helpful for focus and concentration.
Yeah, well, help patients with addiction or patients using methamphetamines and cocaine rehabilitation.
Absolutely, 100%. Yes.
I
Mhm.
tell this story too. I still go to dinner once a year to celebrate life change with some of the patients I've been able to work with over the years. And every single one of those is an addiction or suicide patient. So just again, after a handful of treatments, totally changed their world, still in remission, we'll say. And they try to say, "Oh, Kim, you saved my life." I'm like, no, it's Procaine. That's the effect. So I agree, absolutely. In Florida, we are able to, if we have a sterile hood in the office, 3 or more substances. Obviously, yeah, those laws may change a little bit as you, whatever equipment you have, whatever staff you may have. Um, I had this thought earlier is just a lot of IV rooms are monitored by EMTs, by LPNs, phlebotomists, obviously a lot of RNs. Do you have any thoughts around, is there any special care or any concern you have with somebody of that nature or training or level doing Procaine versus any other IVs?
So interesting. Up until fairly recently, the state of Georgia was allowing medical assistants to do all the IVs. And so all of my medical assistants are trained in doing IVs themselves. They do my EBU, they do my 1 year ago, the medical board of Georgia came down and said it has to be an LPN, RN, or EMT. And so, unfortunately, my very well trained MAs have to be under the supervision of a less well trained so far LPN. So it actually works in the reverse that my LPN is under the supervision of my MAs, but that's not what the Georgia Medical Board knows. So
Well, and obviously know what your board is telling you, and also the other boards, right? The nursing boards. But I would say in general, a safety rule of thumb is that you are, as the medical director, overseeing anybody in your office. And so their training is ultimately on you. The comfort level. This is again where MedMasters really has a focus on creating the standard of care, these SOPs, the standing orders, so that you guys can make that simple and make sure that they're trained well and make sure that they follow that training, because ultimately it is going to reflect you one way or another if something happened. But I did wonder if you felt like this was somehow more, I don't know, dangerous or something that required a different level of attention.
no, I think once they have their first one, like I always will pop by and check on them when they're having their first treatment, particularly the IVs. You know, obviously I'm doing the actual stellates or other ganglion treatments, but the IVs I'll pop in while they're getting their first treatment and go, hey, how are you doing? And the girls are very well trained. I'm sorry, that's very derogatory. My staff is very well trained to, we have all women in our practice, so it's hard not to say the girls. My staff is very well trained to grab me if there's anything at all that's unusual. If the patient's like, hey, I'm having a little headache, hey, they just, there's no need to not have me be in the room. To the patient feels more comfortable, everything goes more smoothly if I get to put my eyes on them.
I always say, oh, protein's so simple, right? It's a one ingredient, maybe two if you're doing the bicarb. You know, the injections, not injections like stellate, et cetera, but neural therapy, it can be so simple. But I never want to try to explain this or the results of it or the experience of it over the phone or over Zoom. Like, you have got to learn this in person, because it can trip out the patient. It can trip out the provider if you don't know what you're looking at, if you don't know what to watch for, again, as the patients go through this. So that's where I would say, like, anybody in the IV room, and especially anybody in the clinic, they just need to know what they're looking at. They need to know what those signs are. The eyes will dilate, people will start to relax, and they will start to experience all sorts of energy changes that can be they're just unfamiliar. And so it brings to mind also one of the things I had never heard before, and maybe this is just I'm old school trained or something, is the pH testing. I've never heard that in terms of checking before doing Procaine with bicarb. So that was really good information too. And obviously if somebody feels really uncomfortable in one way or another, you're going to want to throw a cuff on them. You're going to want to, check all their vitals, make sure things
Oximetry.
are stable. Um, and then document, right?
Yeah,
Like,
we always do vitals before and after. We always get a urinalysis before. If they have heart disease, we get an EKG just to have a baseline, and then you can repeat it. So, oh gosh, look at this. They had this right bundle branch block before they had their Procaine. It's not due to the Procaine. You know, then you're monitoring what their effect is.
all right, well, this has been so insightful. I'm getting all sorts of comments and texts and how great you are and how great this presentation was. I'm not surprised. And then we went over by a long shot, but I think that that was due to good input and extricating information. If you don't mind taking your slides down, I'm just going to share one for us real quick as you guys get ready to jump into your nightly routine. I just wanted to let you know, I said it earlier, but we do have a couple products also that went in. If you're a member, please make sure to check back on this all the time, because as a member, you get instant access to these things as they're available. So you don't need to pay extra. If you're interested in all the ancillary onboarding Procaine materials, if you're doing it already in your office, you need to make sure you have those. If you need to go learn it, then please go to Suzanne's course and learn it. I think the pricing is super reasonable also. And again, it's a great place to go. But if you need some of these other materials, I hope you can see this. MedMasters did drop a couple of products. I don't know what you're looking at. Are you seeing the therapy bundles? And I just exited out. We do have the Procaine. So again, it is your SOP. I did a presentation too. Wasn't there was a lot of overlap with what Suzanne did, but also different. So recorded a Procaine video there. Also your SOP, your informed consent, and these are suggestions. These are things that you can implement right away. I've got some stacking protocols in there. I'm going to go right in right away and add some of the things we talked about today. But that's our Procaine IV bundle here. I know you can see my whole thing. It's on sale today. It's normally 300. It's gonna go back up to 300, but if you purchase it today, you get it for 240. We also did an ozonated saline bundle. Not as common in ozone, but we did get some requests for it. Definitely a valid therapy. So we did a whole group of information there. Also, we put out about 20 individual handouts this month. Again, if you're a member, please don't buy these. It costs us money to refund your account when we don't need to charge you for it. If you're not a member, then you can purchase these singularly or you can become a member. You can go to store@medmasters.org. But again, you want these materials to properly implement this. Informed consent is going to be your biggest thing. And then I wanted to tell you really quickly, our next webinar is going to be on October 9th with Norm Westerfelt. We're totally switching gears here. We're going into fortifying or building strong practices in light of economic changes, political changes. We get a lot of questions. He is specific to helping entrepreneurs grow and again fortify their businesses. Anytime for 15 years, anytime I bring up a business concept, a business a webinar, a business presentation, our registration drops way down, our interest drops way down. And I don't understand it because these things are just as valuable and just as important. So we're going to be talking about, again, how to simplify, how to keep your business up and running, doing really well, no matter what happens in the economy, in politics, with election coming, etc. So it'll be a great presentation. He's a big, it just humbled he would even be with us. So you'll really enjoy that presentation October 9th. When we send out this recording, we'll attach the link to register for that one. So it's equally as important as all the great things that you want to bring in to help your patients. You definitely want to make sure your practice is thriving. So thanks again for being here. It's been a wonderful conversation. I think this information can help you, your patients, your practice. Definitely though, don't dabble in it. You want to get proper training and proper implementation for your entire staff. And so hit up Dr. Ferree at her conference. And to answer your last question, buddy, I think you said like January, February, Suzanne, you might have a second one. There are a lot of work you guys to put together. So the support is appreciative and it takes some time to want to do it again. They are so much work, but they are fun. So thanks, Suzanne, for being here. Appreciate you so much.
Thank you, Kim. It's great to see you.
All right. Take care, y'all.
Take care.